And thank you all for tuning in for this second event in our OI Echo series. We're excited to have everyone here. Last month, Dr. Rush got us off to a great start with the review of diagnosis and genetic testing for OI. And this month, we'll turn our attention to our first surgical topic, lower extremity rotting and correction of Coxa Vara by Dr. Maegen Wallace. I'd like to introduce Dr. Wallace, who's an assistant professor of orthopedic surgery at the University of Nebraska Medical Center. And she also practices pediatric orthopedic surgery at Children's Hospital and Medical Center in Omaha, Nebraska. Dr. Wallace completed her medical school training at the University of Nebraska and then orthopedic residency in St. Louis, followed by a pediatric orthopedic surgery fellowship at the Nemours Alfred I. DuPont Hospital for Children here in Wilmington, Delaware. Dr. Wallace is the director of the OI Clinic in Omaha, Nebraska, and has devoted really significant portion of her clinical and academic practice to OI. Without further ado, very excited to introduce Dr. Wallace, a good friend and colleague, and we're very excited to hear your talk.
Dr. Wallace, you're muted.
All right. Hopefully I'm unmuted and hopefully you can see my slides. Awesome.
Looks good.
All right, thanks for that great introduction. I'm excited to participate, and we've got some great cases to go over today as well. So I think today will be a really productive session. So as most of you know, since you're here at an OI talk, there's different types of OI. In general, we talk about the 4 main types, type 1 being mild, type 2 often being fatal in infancy, 3 being severe, and 4 being moderate. And as we all know, and I'm sure Dr. Rush presented last month, there are many more genetic types as well. From an orthopedic standpoint, our main concerns are the multiple fractures that the children sustain during childhood, the subsequent bowing of the long bones, scoliosis, and cervical spine problems. And today we're going to be talking about the bowing, more so about the bowing deformities of the long bones. Patients with more moderate to severe OI can be born with bowing, or the bowing can occur due to recurrent fractures. And the more bowing that you have, the more likely that you are to fracture. Especially in the femurs, we think about more than 20 to 30 degrees of bowing being more associated with the likelihood to fracture. And in the tibias, I'm not sure that we really know what degree of bowing is concerning in the tibias. And bowing deformities can occur in all the long bones. We see them in the upper extremities as well. Fracture treatment itself is dependent on the age of the patient and also on the size of the patient and how big the bones are, and some of it's surgeon preference as well. And when we talk about fractures, when we talk about surgical interventions, we have multiple implants that are available, most commonly the FD rods. The slim nails are also out on the market. Depending on the severity of the patient, sometimes flexible nails are reasonable. And then depending on the size of the bone, sometimes all we can get is something in like a K-wire. And then in the older patients, rigid nails are a possibility as well. When we talk about fracture treatment options, in the very young or the very small patient, sometimes just a splint is all we need if the patient's not large enough or old enough for surgical intervention. The real small babies, sometimes even a Pavlik harness is all we need. Spica casting can be used as well. And then in the tibias, either casting or splinting. When we talk about surgical management, especially an OI bone, we know that plates and screws are not always a good option alone in the bone when you have OI. Non-telescoping intramedullary rods can be used in very small bones, but obviously those types of rods, as you can see in the tibias in this x-ray image, they don't telescope or grow with the patients, and so there's always concern about stress risers at the end of these rods once the children grow. And then our telescoping rods are the rods that we classically think of when we think of intramedullary rods with OI. And these rods, quote unquote, grow with the children and to try and decrease the number of surgical interventions that they need and to decrease the number of fractures, which is really our goal. Keep our patients with less fractures and less need for surgery and as functional as that patient can be. So with bowing, with surgical management, there are lots of studies and lots of us around the country that will operate on multiple bones in one sitting. It's been found to be safe to do this, and it decreases the number of total anesthetics that the patients need and the total number of surgical experiences that the children have as well, which is important as they continue to grow and develop. Young children can be treated safely with osteotomies and intramedullary nailing, and it's safe to be done when the children start to stand or when their fracture risk goes up. And I don't think there's a minimum age to safely do surgery. So just a little brief history. When we think about lower extremity rotting, Dr. Sofeld and Millar in 1959 published their 10-year outcomes on patients with OI with fragmentation, realignment, and intramedullary rotting. And you can see from these pictures from their original article that this was quite extensive surgery. These were large incisions with realignment of the bones. And they actually showed nice outcomes in their paper, but we know these are large incisions, and at that time with stable implants that didn't grow with the children or telescope with the children. But this is kind of the basis for our orthopedic management. This is a study from 2011 that showed 60 patients who had had femoral rotting surgery. The mean age of their first rod, you can see there was 3 plus 11 years, with the range from anywhere from 1 to 11. And they looked at different functional outcome measures and also looked at fracture outcomes as well, both preoperatively and postoperatively. And they found significant benefits for rotting in these children. They found benefits in ambulation, in gross motor function, in patients' ability to care for themselves, and really for their mobility. And this actually, some could argue, oh, that was just normal development of the child, but they actually found it was beyond what the physiologic expectations would be just due to developmental growth in these children. This is another study from 2011, which showed early follow-up, just 1 to 2 year follow-up. And they showed that this study showed that lower extremity rotting is safe. It showed a fairly low reoperation rate for proximal rod migration of 13%. They did show 40% complication rates, mostly with rod migration or rods that didn't telescope any longer. They found 2 female rods that migrated in one type 3 and one type 4 patient, and 3 male rods that no longer migrated or telescoped. And then they did find 1 patient who had an intraoperative joint intrusion. But again, overall, good outcomes, lower fracture rates. And you can see this X-ray here that I have is actually a patient that we follow here in Omaha. And you could argue, yes, the left tibia rod obviously didn't telescope probably for very long after it was put in. But this patient, once the bone was mechanically aligned, that patient hasn't had any more troubles with the bone. So technically it would be a complication in a paper like this, but for this particular patient, the functional outcomes, especially for that bone, have been fantastic, and she hasn't needed any other interventions. This is a study that came out in 2018. And their main goal was to look at whether there was a difference in fracture rates or need for repeat surgery with FD rods versus just static implants. So rods like a rush rod or a flexible nail or a K-wire or Steinman pin that doesn't telescope with the patients. So this study had 64 limbs in 21 patients. And you can see the number of femurs and tibias here. And they actually found that the patients that had static implants failed 13 times higher than patients who had the telescoping rod. So you can see their conclusion is amongst surgically naive limbs, FD rods were associated with significantly improved probability of survival than with static implants. And I think this is a great example of why, even if the telescoping rods don't telescope, there's a chance that they will, and the outcomes are much better with less reoperation. This is a patient of ours who at 14 months of age underwent bilateral femoral nails we were able to correct most of the deformity in a somewhat closed or percutaneous manner. And then 19 months later, he sustained a fracture of the left femur and bent the nail, which then we all know that with these patients, when they have fractures with the rods in, they're much less traumatic. The pain is much less, and instead of needing to do a rod or some sort of surgical intervention in a more urgent manner, this was revised about a month after his fracture in a much more scheduled fashion, and we were able to then revise the rod and straighten the leg out since it was early in the fracture healing without having to do an open osteotomy. This is a study done by my senior partner, Dr. Esposito. He published his first 58 patients in 2018. You can see there are a large number of femur and tibias with surgery, and the mean age at surgery for these patients was 48 months. But it ranged from anywhere from 13 months to 16 years. You can see there are 9 type 1 patients, 29 type 3, and 20 with type 4. And 30% of the patients out of these 58 had both femurs and both tibias done in the same operative setting. There was a 53% revision surgery at a mean time of 4.3 years, with the most common reasons for revision surgery to be fracture, rod migration, and also non-unions. There were 24 tibial rods that stopped telescoping at 18 months and 4 that stopped telescoping at 24 months. It's much more common in the tibial rods that we've seen where the rods will stop telescoping than in the femurs, but it can happen in both. So here is another patient, a 2-year-old female with type 3 OI. When she was first born, her severity was her bowing was quite severe, and she was starting to show signs of pulling to a stand right around 2 years of age, and so that's when we decided to intervene as she was showing interest in starting to try and pull to stand and walk. And so we elected to do both her femurs and tibias to give her the best outcome and the best chance of being able to progress with her milestones without having significant fractures. She ended up walking independently about 6 months after this procedure. And you can see here's another patient of ours that was adopted, and at the first time that we saw her, she was 8 years of age and had never had any operative intervention. And we ended up doing both her femurs and tibias in one sitting as well. And she's done surprisingly well over the years. And you can see her rods telescoping. This first image with the rods in is 2 months after surgery, and the one on the right is a year after surgery. So you can see how much she had grown after the rods were put in, and that she maintained her alignment as well. For those of you that are orthopedists in the audience, I would encourage you to read this paper that Dr. Fassier came out with in JPO. It's really nice. I love all the pearls and all the tips that he has in here. And it's nice to kind of see a little bit of how he thinks about deformity correction with the FD system. And so I just wanted to highlight some of the things that he had in this very nicely done paper. So he says that he ideally reserves rodding for children who have reached walking age, that the deformities of the long bones over 20 degrees of bowing are a good indication for osteotomy and FD rodding. And also the number of fractures. If there have been 2 fractures in the same bone in the same year, then it's worthwhile to consider rodding for that patient. But knowing that non-displaced and incomplete fractures can be treated conservatively, but certainly if the patients end up with even a non-displaced fracture over and over and over again within a year that's limiting their function, it's worthwhile to think about. He recommends delaying surgery more than 48 hours after a bisphosphonate infusion. And then he did mention in this paper 1 limb versus 2 limbs at a time and 2 versus 4 bones. But does recommend fixing the femur first, which we do here as well. And then once the femur has a rod in place, then using a tourniquet to do the tibias has been found to be very safe as well. And then the number of osteotomies in a particular patient is really patient specific and is specific to the bone. It depends on where the deformity is, how many deformities there are, and if you can, how many osteotomies it takes to get that bone straight to be able to get the rod in place. And then always try percutaneous or closed osteotomies if possible, just to decrease the biologic insult and the number of incisions on the patient. And then the choice of rod size for diameter that allows for stabilization but not stress shielding. So it's important, you know, in classic orthopedic teaching, we think, you know, the larger the rod in place, the better. But we know with patients with osteogenesis imperfecta, if you put a rod that's too large in place, that bone doesn't see enough stress, and you'll actually start to lose some bone stock, which isn't ideal in these patients. So I just have a few pictures that how we do our rodding here in Omaha. So we classically will do epidurals for pain management for our femurs, and definitely if we're doing bilateral femurs or all 4 bones. I like to be in the room while they're putting the dressings on for the epidural dressing, because if you're not careful, your anesthesiologist and these real little kids will get the dressings awfully close to where you need to have your drapes and your incision. And so I do like to protect that area. And then we like to do the femurs in the kind of a sloppy lateral position. And so you can see this position that the patient's in for the epidural is the same position that she'll be in for the surgery as well. And then utilizing our incision proximally to gain access, and then having our C-arm come in from across the table to take our images that way as well. And then a couple of ways that are really nice for doing your percutaneous osteotomies. One way is sometimes if you get lucky when you get your wire down, the wire will go out the anterior bow of the femur exactly where you would want to do your osteotomy. And so we found if you leave the reamer in place, and then you can do a closed osteoclasis or cause a fracture at that site, and then be able to tap the wire down across that location of your osteotomy. Sometimes you don't have to make any incisions, especially in these real small children. The other way that is nice to do this is just with a real small percutaneous incision and a drill bit with C-arm to help localize where you're going to do the osteotomy. And then either complete the osteotomy just with your hands or with a small osteotome can work nicely as well. And then you can see the length of the incisions when you do these percutaneous can be relatively small. Here is another, this is actually the x-rays of the patient that I was showing in that for the clinical photos there. She had her bilateral femurs done. And then just to briefly touch on Coxavera. So Coxavera is where the neck and the shaft of the femur is decreased. Normal, you can see there's about 130 degrees. We usually call it Coxavera less than 110, but oftentimes our patients with OI, their Coxavera will get significantly lower than that as well, as you can see in these radiographs here on the right. Patients often will present with hip or groin pain, and the patients, as they develop Coxavera, sometimes they'll be walking fairly well, and then slowly over time develop more of a waddling gait, and this is something we should keep an eye out for. It can be very common, or much more common in more severe types. So this study out of Montreal showed an overall rate of 10% in their patients, and you can see the breakdown there with the type 3s up to 55%, type 4s at 24%, and then less after that. They also showed that with the 29 patients that had Coxavera, you can see it's relatively equal in terms of left and right side. 36 of the hips had previous femoral rods, and only 7 of the hips didn't have any rods. So as a orthopedist, we're always questioning whether our interventions are causing other troubles as well. And I think there's probably something to do with either the location of the rod or the way that the femoral neck sees stress differently with a rod in place. It can be a difficult problem. With OI bone, implant selection is limited, and unlike other options where of children who have Coxavera but don't have soft bone, we can use plates and screws. In OI, it's not that simple, and so we have to think of other options to use. And this is again out of Montreal, and showed, you can see here the steps of correcting Coxavera to be able to get the neck shaft angle better. Usually we have to revise the rod if there's an FD rod in place, and then do the femoral necks, the wires of the femoral neck, and secure those around the shaft. You can see that pretty powerful correction. They found they had an average correction from 84 degrees preoperatively up to 114 degrees postoperatively. In their paper, they showed few complications. And here you can see some images from that paper with the nice correction and the correction that's achieved and then also maintained over time. And this is actually just a recent case that Dr. Esposito and I did that when I was preparing for this talk. You can see she just gradually over time developed Coxavera, but you can also see a stress reaction and a fracture forming of the femoral neck in that area as well. And that's what I have together, and hopefully we can either address some questions or go on and see some other cases.
Yeah, thank you, Dr. Wallace. Terrific talk. Are there any questions from the audience here?